The death toll in DRC's Bundibugyo outbreak has now passed 500, and the response is scaling up at the same time. If you're just joining, here's where we were before this ministry report. The Bundibugyo outbreak was already centered in eastern DRC, with Mongwalu among the hotspots, and teams were dealing with tough field conditions, treatment needs, and steady transmission. Earlier reporting also showed pastors and churches trying to counter misinformation and turn public health guidance into trusted local action. A reminder that containment here depends on community trust as much as clinical capacity.
This is Ebola Watch. Today, a number we've been bracing for, a university turned into a nerve center, and DRC's top Ebola scientist with 2 words: still hope. Let's get into that 500.
Here's Shiyu at the Star.
According to the report, the country has recorded 1,561 confirmed cases, including 506 deaths. A total of 254 patients have recovered, while 628 confirmed patients are currently in isolation or hospitalization. Authorities also identified 354 suspected cases, including 110 deaths.
The latest DRC Bundibugyo update. Deaths have now passed 500. The Health Ministry's Sunday report puts it at 1,561 confirmed cases, 506 of them fatal, and separately, 354 suspected cases with another 110 deaths.
500. That's the number I've been bracing to say out loud all week. So what's the case fatality rate here? Because people have the old Zaire strain math in their heads.
On the confirmed figures alone, it's roughly a third, 506 in 1,561. But Bundibugyo has historically run milder than Zaire, so I'd hold that ratio loosely. It'll move as outcomes come in for the 628 patients still in isolation.
And the trend line isn't cooling. Epi weeks 25 and 26 each topped 300 confirmed cases, the highest since this started, across 36 health zones. That doesn't look like a response getting ahead of it.
Community transmission is still running, the one genuinely forward-looking line in this report. WHO says a clinical trial started enrolling patients Thursday at the CME Treatment Center in Rwampara, Ituri, the epicenter itself. From Fred Uma at Makerere University News.
Delegates, dignitaries, and diplomats gathered in the tent outside the Infectious Diseases Institute, IDI, a research institute owned by the university, for the formal launch of the Continental Incident Management Support Team, IMST, a joint Africa Centers for Disease Control and Prevention, Africa CDC, and World Health Organization, WHO, operation racing to contain the Bundibugyo strain of Ebola sweeping through the Democratic Republic of the Congo and, increasingly, Uganda.
Okay, so this is the thing I flagged Wednesday, the room full of flags. Now it's real. They cut a ribbon Saturday at Makerere's Infectious Diseases Institute, and there's a Continental Incident Management Support Team with actual people running it.
And it has names attached, which matters. Dr. Chris Berriomunsi cut the ribbon, with Tolbert Nyenswa, Marie-Rosaline Belazaire, and Andrew Kambugu there as well. This joint Africa CDC and WHO operation gives the response an actual command structure.
A command structure in a car park, per the article. Which, honestly, is more reassuring than it sounds. That's speed, not disorganization.
What I'm trying to pin down is whether this is the same Kampala logistics footprint we surveyed last week. The national medical stores, the WFP base, now formally folded under this continental umbrella. Or is it a parallel structure? Because coordination between DRC and Uganda isn't background here. It's one of the things that decides whether control works, and this room has both sides in it.
And this comes right after we hear deaths cross 500. So the timing's brutal. You stand up the nerve center in the same week, the death count crosses 500.
Here's Magini Diba at the Good Men Project.
Unlike the Zaire strain, for which a vaccine and treatment already exist, no licensed vaccine or curative treatment is currently available for the Bundibugyo species of Ebola identified in the current outbreak. The development of a new vaccine is expected to take several months.
So we just walked through the 500 death number.
Muyembe, the man who co-discovered this virus in 1976, is on the record with SciDev.net saying, "There is still hope for this epidemic." I'll be honest, that lands different coming from him than from a press office.
It does. And notice what he isn't doing. He isn't promising a countermeasure. He says it plainly. No licensed vaccine, no curative treatment for the Bundibugyo species, and a new vaccine is months out.
Which is the part that stops me. For Zaire Ebola, we've got a vaccine and a treatment. This strain, nothing on the shelf. So when he says hope, it's not because there's a drug waiting in reserve.
I'd frame it slightly differently. For him, hope means supportive care, early detection, isolation, the tools that worked before the vaccine existed. Coming from someone who's been at this since '76, it sounds like clinicians' realism more than spin.
Fair. And the case figure in this piece, over 1,200 confirmed, 321 deaths as of June 25. That's a tighter, older cut than the 500-plus we just cited from the Star.
Right. 2 different snapshots, 2 different dates. The Muyembe interview freezes the picture on June 25th. The ministry number is later. So the climb from 321 deaths to 500-plus is acceleration, not a discrepancy. Both figures are confirmed cases, and that distinction keeps the fatality read honest. This one's from CDC.
CDC is responding to an outbreak of Ebola disease caused by Bundibugyo virus in remote areas of the Democratic Republic of the Congo, DRC, and Uganda. To date, no cases of Ebola disease have been confirmed in the United States because of this outbreak. The overall risk to the American public and travelers remains low.
So CDC's page still says the risk to the American public and travelers is very low. And it's dated June 26th. After the 500 death number we just hit, that feels like a snapshot from another week.
It's dated, yes, but the assessment itself isn't wrong. Low likelihood of spread to the U.S., strong infection control here, those still hold even as the case count in DRC climbs. What I'd flag is the framing. CDC calls this the 3rd largest Ebola outbreak on record, past 1,000 confirmed by June 22nd. That word, confirmed, matters there, and it's the honest way to count.
Right, and both countries declared the same day, May 15th, after labs confirmed Bundibugyo. So for a parent of a Peace Corps volunteer in Uganda, all the Ugandan cases are still in Kampala, per this page. That's the geography that actually matters to them. If this is the first time WHO has formally approved a diagnostic test for Bundibugyo Ebola, what were health teams using to confirm cases before? And does an official listing now change the numbers we've been seeing?
Great question, and the honest answer is teams were working with tools that were never purpose-built for this particular virus. Bundibugyo is a distinct species. Its full name is Ortho-Ebola virus bundibugyoense, and it had only been identified once before, in Uganda in 2007. So when this outbreak surfaced in Ituri province in early May, the DRC's National Biomedical Research Institute, the INRB, was running tests in Kinshasa on samples shipped in from the field. Per the WHO disease outbreak news, INRB analyzed 13 blood samples from Ruwampara Health Zone on May 14th and confirmed Bundibugyo virus disease in 8 of them by May 15th. That's what triggered the official outbreak declaration. But it meant relying on centralized lab capacity, cold chain logistics to get samples to Kinshasa, and turnaround time that slows everything down in a remote area like Ituri. The Wellcome Trust flagged in late May that there were no licensed countermeasures, vaccines, treatments, or rapid diagnostics specifically approved for Bundibugyo, and that's the R&D gap this listing is meant to start closing. WHO's emergency use listing formally validates a molecular test, one that detects the virus's genetic material directly from a blood sample. That lets labs in affected countries procure it through official channels, qualify for international supply support, and use results that are legally and clinically recognized for case confirmation, without routing every sample back to a reference lab.
So if confirmed case counts were bottlenecked by lab capacity this whole time, does that mean the numbers we've been hearing are probably undercounts? And could the listing trigger a sudden jump in confirmed cases?
That's the key thing to watch. NPR reported in mid-June that Ebola testing in DRC has improved, but still isn't close to sufficient for the scale and geography of this outbreak. So the gap between suspected, probable, and confirmed cases is real, and those are distinct WHO categories, not interchangeable labels. As faster, field-deployable testing comes online under the emergency use listing, confirmed case counts may rise. Not necessarily because the outbreak is getting worse in that moment, but because more infections are moving from the suspected or probable column into confirmed status. Listeners should read any near-term count increases with that context in mind.
If you've got feedback, a story idea, or a correction for the Ebola Watch team, we'd really like to hear from you. Send us a note anytime at ebolawatch@lanternpodcasts.com. We've put links to every story from today's briefing in the show notes, so if something stuck with you, you can find the source and read further there. That's Ebola Watch for today. This is a Lantern podcast.